if you are doing truly 10% revision, I think it means that you are a good surgeon. If you are doing 20% revision, I think it's a little bit too much. If you are doing 2% revision, it means that you have a big problem in your evaluation.
Ladies and gentlemen, welcome to another episode of the Rhinoplasty podcast. We are really excited for the month of August to be focused on preservation rhinoplasty, and which company could be better suited than Comec from France, who make these fantastic piezo machines that are such an important part of preservation rhinoplasty. So shout out to the guys from Comec. Now, if you guys listen to the end of the podcast, I'm going to give you the details of the person you email, and you get a 10% discount on these machines. But I'm not going to give it now, so you just have to listen to the end. Okay, so let's kick it off. Today, we are so honored to have the Godfather of Preservation Rhinoplasty on the show. I've been following this incredible human being for many years. It's amazing what an inspiration he is to so many people around the world. He had a huge influence on me, making sure that I passed my facial plastic board exams, that I've just become passionate around rhinoplasty. And we're very excited to also be being hosted by this man for the Nice European Academy of Facial Plastic Surgery's annual general meeting, at least the Congress in Nice in September. So, Prof. Yves Saban, thank you so much for being part of the show tonight.
Cam, thank you so much. You know, we love you, especially here in France, so we do appreciate your invitation. And for us, really, it's a great pleasure. And for me, being with you is like being on holiday, so I enjoy this time, and I will try to share with you. Thank you very much also for the kind words you said for me. I do appreciate, even if, you know, I think that rhinoplasty making us a little bit humble, because it's every day it's a lesson of humility. So, as I told you before, so today I had to do 3 rhinoplasties and 1 autoplasty, and everything is, every rhinoplasty, every surgery is always different according to the patient expectations, according to our experience, according to the anatomy. So it's very interesting, and I really am very happy to be here with you and trying to share something about that. Thank you, Cam, for the invitation. I enjoy it.
Oh, well, thanks. I'm looking forward to a really nice evening.
Oh, excuse me, I interrupt you. Cam,
yes.
Because you are talking about the recent past exams, so you passed the certification. And I remember when we met the first time, I told you, you were so not knowing exactly what to do. And you were, at this time, you were much younger than now. And but even if you're still very young, and I told you, you should pass these exams because it will be very important in your life and your career. And so go on. And I remember we met in Amsterdam, and you told me, oh, Yves, you pushed me a lot, but you did well. So now I am certified, and I'm very happy with that.
Thank you.
Congratulations for your journey.
Thanks so much. Sure. So I know on behalf of the listeners, and we now nearly 70 countries around the world, we've been downloaded more than 15,000 times. So people are hungry to learn about rhinoplasty. But we want to get a little bit more background before we climb into this preservation thing. Tell us a little bit about what makes Yves Saban tick. I mean, you have done so much in your life. What is it that inspires you to do the things that you do?
It looks an easy question, but in fact, it is not that much easy. Well, you know, things are appearing in time in your life, and you are doing some techniques. And while you are doing some techniques, you learned when you are a resident and starting the specialty, and then you can see some limits of these techniques, looking back behind you and seeing the patients. And then you are not very happy with everything that you learned, and you don't feel that much comfortable. So you say there is probably another way to perform the technique. So you are just thinking about that. And so I learned with, it was in the early 80s, and I started with, let's say, with Jack Sheen principles. And I was very happy with the result, but I was beginning, so I have no idea of what could be the future of my surgery. and I was happy. But as you know, at the same time, I was going in the anatomy lab many times because I was doing at the same time the specialty of ENT and maxillofacial, so I was very busy. And going in the lab, I could check really the anatomy of the nose and trying to understand what is behind or under the rhinoplasty techniques. And when you are going to the lab, then you discover that it's more complex than you can imagine, because when we are learning generally one technique. It's how I started learning one technique and doing always the same technique on all my patients. Of course, in some patients I could get excellent results because it was very good technique. And in other patients, I had not good results, and even sometimes pretty bad results. So the anatomy lab helped me a lot in understanding the anatomy and understanding why in certain circumstances the results were not what was expected. And then I started with that for years. So I tried to understand, adapting the technique to the new tricks we could learn in the books, because at this time there were much less meetings than what we can have nowadays. And then I started like this. And about, let's say, a few years after, I started making courses of anatomy, surgical anatomy in Nice, in the anatomy lab, about two things, about the rhinoplasty on one hand, and on the other hand, the facial aesthetic procedures. And so I had to work a lot, because at the moment you are starting teaching something, even if it's surgical anatomy, then you must understand what you are doing, because you need to explain how things are going. If you are not clear in your mind, you cannot explain. So teaching is helping you in better understanding, and at the same time probably improving ourselves. So that when I started this, I said, okay, I was satisfied, but not completely. So I started to train to practice the Cutles technique, and it was in the early 90s. And but Cutles technique looked to me like a little bit strange, probably like for many people, maybe everybody. It was like, if you want to clean, I said this like this comparison. It's like if you wanted to clean your ear, then you are using your right hand to clean the left. You understand what I mean? Yes. Cutles technique is something like this. So because when I started to trying to understand it, what we wanted to achieve in rhinoplasty was, let's say, removing the hump. And what we are doing in Cutles were removing everything except the hump. So it was strange for me. So I went in the lab, tried to understand, follow the technique. And then I found that in some cases it could be very interesting. So I started in this way. I have no personal mentor or teacher teaching me the technique. So I had really to try it in the lab, with the anatomy book on one hand, the textbook on the other hand, and trying to understand better this. And then slowly I could improve myself learning that. And then I could see also the limits of the Cutles technique, because we cannot, in the same way that we cannot always perform a resection or preservation of structure or whatever the technique. I could see the limits of the Cutles, and so I could also have some bad results. So you have to, when you have bad results, then you have to think about that. Why did I have a bad result in this case? You have to go back to the technique, to go back to the patient. And then I heard about the high strip technique, and that was an option. It was in, let's say, 94, 95. And so I started, okay. But again, no special mentor, just go to the lab and trying to understand what is the high strip technique. So I went to the anatomy lab, trying to perform some high strip procedure, and then I understood that it was very interesting, because it was much easier for regarding the septum, and it was also the results looked more predictable. And then I started this slowly. But as you know, when you are alone doing a technique, then people are looking at you like a ET and saying what he's doing strange things. We don't understand what he's doing. So hopefully my friends were pretty, let's say, polite, just listening to me and saying, okay, who will be the next speaker now to understand something better? Because I was like preaching in the desert, and it was a very special time for me. And it made me also very humble, because when you are for years and years, you are preaching in the desert, then you feel really alone. But okay, you have to go on and show some perseverance or resistance to this. And once, sometimes something can happen in your life. It's like a star. And so we were with Barish in Budapest. It was in 2016. And Barish Chakir told me, Yves, you are talking about one technique, but to speak frankly, I don't even understand what you are doing. So could you explain me what? So I told him, yeah, with great pleasure. You are the first one who is asking me to explain something about that. So, but I waited at least 20 years without anybody interested in that. And so I showed to Barish, it was a big nose, the big deviated nose. I told him, look, I will be very quick just to show you that in 10 minutes we can make the nose straight, and straight on profile and straight in face view, front view. And he told me, no, I don't believe. I thought, yeah, you will see. So I could do this very quickly, not showing anything, just that it was possible. And Barish told me, okay, it's very strange, but okay, can you do that now very slowly, explaining the step by step, to that I could understand what you are really doing, because it looks very strange to me. So I did again. It was a big nose again, T4 nose. So I did that very slowly, explaining every step. What was very comfortable with Barish is he's a left-hand guy, and I am right-hand. So we could be two surgeons at the same time. So it was very nice. And so I showed this to him. And then after, Peter Palazzi was with Olivier Jabot were also in the room. It was in Budapest. And okay, so Barish told me, okay, we are not here for making that, but I would like now you to help me I would like to make the procedure to understand how it works in my hands. So I explained to him. And what shown very nicely Barish now is that when I showed that to him, he started almost crying in my arms, saying, "Oh, Yves, I have just published a book and I must change everything now." So it was very special, and I was also I felt like a big emotion inside, because
yes.
Okay, the guy is interested. He is a very kind, clever, smart. And maybe there is a way to spread a little bit the idea, because when you are alone, you feel alone, and you are really alone. Yeah. So this is the truth. And when you are two people, okay, things are changing, because you can feel some support, and things started like this.
That's amazing, eh?
I'm sorry, I was a little bit long, but it's...
No. It's fascinating to hear this. I mean, this is a 40-year career, and you're there for 20 years and no one's listening to you. Unbelievable. Before we get into the actual topic, a quick question. Tell the listeners a little bit more about the Nice meeting in September.
Oh, thank you so much for asking this question. Yes, we are really working a lot on this meeting. It is the annual meeting of the European Academy. It will be the first face-to-face meeting since a few years, 2 years now, except Budapest, the one who was done in Istanbul with Göksel and Barish. Mm-hmm. We were there, and so this meeting will be, at the moment, it's not a rhinoplasty meeting. It is a European Academy of Facial Plastic Surgery meeting. So I'm just the one who is organizing in Nice the annual meeting of the European Academy. And at the moment, we have almost all the faculty has confirmed the participation. We have some doubts for our English friends, because there are some difficulties between England and France at the moment. But I hope at least that in September everything will be okay. Otherwise, we have like almost the top 50 rhinoplasty surgeons coming here in Nice. It will be the biggest rhinoplasty with the biggest names, except 2 or 3 who could not come and join us. But really, it will be for the people and friends and colleagues who are want to improve their skill and knowledge in rhinoplasty. We have organized it will be 4 days meeting, and in these 4 days, in the biggest room, we will have for every half an hour we'll have a master class. So for 4 days, from 8 in the morning till 7, we have master classes done by all the biggest names in rhinoplasty. And I think it will be a fantastic opportunity really to not only to see and to teach and to discuss with them, but also to get something. And that, okay, you understand, taking something and going back home with these messages. But just to finish with that, we have 2 other rooms. In one room, there will be everything regarding facelifts and facial procedure. With the first day, we have also very big names in facelift coming in knees, and we have also a session on facial palsy, how to treat once the paralysis is installed, and so we will go in this way with facial reconstruction and others. And in the last day, in a room will be completely dedicated to oculoplastic surgery. So on one room we will have still rhinoplasty going on. On the middle it will be oculoplastic from 8 in the morning till 7 in the evening. And in the third one there will be more cosmetic procedures and aesthetic procedures. So it's really a very big meeting. And we are really working a lot, and of course we are a little bit in trouble with these regulations due to the virus.
No, but we're very excited. I can't wait to come over there and see everybody and be part of this. So the last question in terms of that, is there a website that people can register on?
Yes, thank you so much. Yes, the name is very easy. It is EAFPS, European Academy, NICE, NICE 2021.com. It's so EAFPS NICE 2021.com. So you are the ones who are interested are more than welcome. At the moment we are at about 300 people, including the faculty, and we have many the partners for surgical instruments, and exposition is almost full. So it's for us it's very important because, as you know, when you are running meetings, you know to support, because otherwise you are organizing a very, very nice meeting. You have plenty of friends, but it can be a little bit difficult for yourself. It's sometimes painful in your pocket. So you try to be at least equal, so you're not losing too much money in this meeting.
No, definitely. Okay, so whilst you get your talk for tonight up, I've got one last question for you. What do you do when you're not doing rhinoplasty? What do you do to relax?
Well, my life, difficult question. Hopefully, I'm working with my wife and my daughters, so at least I can enjoy being with them. I have a small house just in front of the sea. While I'm seeing you on the screen, if I just look over the computer, I see the sea with some boats on the sea, and Cap Ferrat, that is a very nice place. So when I have time in the morning, I'm going swimming with Sylvie, and otherwise my life is very filled with rhinoplasty procedures, or organizing meetings, or reading other books, or whatever, But it's true that sometimes my family is complaining about that I'm not giving them enough time. So I do apologize. It's very difficult, but they are right. Of course, they're correct.
We were going to have you and your family in South Africa last year, but thanks to COVID, that never happened. But we will in the future. Okay, so can I ask you to share your screen?
Okay.
And whilst you do that, just a reminder is quite a few of the people are not able to necessarily see what you be sharing. they can obviously hear on the podcast. So you can maybe try and describe one or two of those slides for the listeners who are unable to view us through YouTube.
So, Cam, do you hear me now? Because I have my
Perfect.
Is my screen okay?
It's lovely.
Okay, super. So, please, Cam, don't hesitate to interrupt me. You will not be unpolite. It will be more than welcome. If you want me to be quicker or to explain something better, because sometimes we don't know what is interesting for our friends. So I would like really to share with our friends and with you. So you are the one who is really able to interrupt, saying, hey, okay, if you say that, but I didn't get exactly, or could you give me some more details? Or on the opposite, you can tell me, okay, if you told that so many times that everybody knows that, please go quicker. So don't hesitate.
Okay, thank you.
So this is the logo, this face, this was a painting that was done by a good friend of mine, and for the book I have done a few years ago. And so I'm very pleased to use this like a logo with a face, and it was an aquarelle. As you know, I'm working in Nice, so I have many certifications in facial plastic, maxillofacial, ENT, and anatomy. And I am currently the chairman of the European Academy of Facial Plastic Surgery, Rhinoplasty Focus Group. And I was past president of the International Rhinoplasty Research Society. This society is very important in my heart because it was where I could meet many of our friends, and I will show you the photo. And it was one of my important starting points in my rhinoplasty career. And I have some disclosures because, as you know, we must share that for some books and from Ibsen because I am consultant for Ibsen. So thank you again for your invitation to share this meeting in Nice. It will be from 15 to 18th September in Nice. And at the moment, we have very nice weather. And I do hope that you will be able to see, if you see this on the screen, we will be here on the meeting room is here, so it's very close to the airport and very convenient for everybody. And this is the website. So rhinoplasty is a family group, I say, and we are not working alone. When you are working a lot, you are alone. It's a very sad time, and even if you love what you are doing, so it's very important to belong to a group. And so I have different groups where I'm involved in, of course, the European Academy. This is what I can call some connection I have with in Turkey with Göksel, with Fazil Paydin, and also with many others that are very good friends of mine, and really that whom I love a lot. And this is the IRES group. It is a very small group, 10 people, sharing their experience, because as you know, to share and to think all together, it cannot be hundreds of people. So this is a very small group of people. We are sharing some ideas, and like French, you can recognize Olivier and me. And and this is the most important starting point of the preservation rhinoplasty with you know everybody, Roland Daniel, Peter Palazzi, Daris Chakir, and myself. And I think it was a very good team because we all of us, we are very different, and this difference is making the success of something. If everybody is the same, you cannot improve because you are. In French, we say we are turning in around. I mean, it's always the same things. So this is rhinoplasty. This was my medical thesis on lateral osteotomies in rhinoplasty and in fracture. It was in 1984, so as you can see, it was 37 years ago. And in the meanwhile, I wrote with some friends this in 2002, the book on rhinoplasty. And we have had the chance of having Tony Bull, Jibayash, and many very big names, Pitangi and others, participating, Jim Tardy, and so I will not make citation of all of them. But thanks to them, we could make a very nice book in 2002. And this is the last book on rhinoplasty that now everybody knows. And these are some books, because I told you that I'm going many times in the anatomy lab. That was like my second house for a while. So I published this anatomy book in 1994, and Jean Tardy made the preface. Then in about 15 years after, I published this book on central face anatomy, and this one on facial anatomy for cosmetic procedures. And I think there are three very different
So
books.
can I ask a question here?
Sure.
Your first publication, that was in 94. How much has your understanding of anatomy changed in these 25 years or 27 years?
It's interesting. At the beginning, when I started with this book, I told you I was already organizing courses on surgical anatomy for rhinoplasty and for facial procedures, facelifts and others. And at the beginning, before we published this book, anatomy books were true ones. I mean with dissection, not with only drawings or something that you can find copied from hundreds of years, so for centuries in the books. I don't say that it's useless. I think that drawings are very important to explain something, but the anatomy you cannot understand if you are not retouching the things, and if you are not going to the lab, then you cannot understand. And what I could see during these years is that we could understand better not only the basic anatomy, but we could see the variations, individual variations. And that is very important for the facial procedures, because, for example, if you are interested in mimic muscles, if you are interested in nasal muscles, if you're interested in ligaments, if you're interested in compartments, then you can see that depending on each one, each of us, we have a different anatomy. We do not look at the same way. We do not smile in the same way, because we do not have the same muscle. It does not mean that some people are sad and someone are very happy, but our mimicry is really depending on our muscles and also the fat compartment all the facial compartment that are really creating the true anatomy of the patient. And this is what really changed these 25 last years, because we could rediscover that, including the facial ligaments, as you know, discovered and precised by Stutzin and some others anatomists years ago. And my two most important books on anatomy were on orbital anatomy. It was I learned a lot from Gels, and I'm sorry. And there were two big authors, big names of oculoplastic surgery, and also from Jean Tardy anatomy book on the nose, where I learned a lot. So I could understand that the real dissection is the key, and you cannot be only teaching through drawings, because it's really not the true anatomy. So, Cam, is it okay?
Perfect. Keep it up. It's great.
So the nose, this is one cross-section I have done. All the anatomy I will show I have done them. So this is a cross-section I have done on the head. Now it's more difficult to do that because of some regulations in France for the anatomy. But I could do this, hopefully. So we can see very nicely the nose, the hard palate, the soft palate, the inferior turbinate, the middle turbinate, the ethmoid sinus, the frontal sinus, the sphenoid, the sella, and the brain. So it's interesting, because when we see that, we can see the relationships between the external nose and what is inside, including the turbinates, that is the function of the nose. And now you know that a lot of friends are talking about the skull base, because they are afraid of manipulations with the septum. So when we are working on the nose, we are working on the aesthetics, but also it has some connections to breathing and olfaction, and we should always evaluate our patients regarding these three functions of the nose: olfaction, breathing, and aesthetics. So, as an introduction, I repeat that, I'm sorry, but I think that it's important that all our friends understand that there are different philosophies in rhinoplasty. if we are talking about resection, okay, we see a patient, we say, okay, I have to resect this height of hump to get the good result. So this is I started this way. And then when we are thinking structure, generally we are thinking how to build the nose I would like it to be. So we are always thinking about grafts and modifying the nose in the way we would like it to be. While in the preservation, the philosophy is how to modify the nose according to its natural anatomy and improving this anatomy to make it more natural, not natural, but nicer and more convenient for the patient for his life or her life. So the concept of preservation was to preserve as far as possible what we can preserve. I mean, soft tissues, key area and nasal valve, and also the lower lateral cartilage. And just to say that how much I was involved in the anatomy, I published, as you may know, in 2008, the superficial musculoponeurotic system and an anatomical study of that with the applications in rhinoplasty. And it was, I think, the true basic study talking about the ligaments of the nose, talking about the pitamidie. That was not really a democartilaginous ligament like it was said before, but it was a mass extension. And I think it was a good starting point for the new anatomy of the nose. And I also published something about the vascularization of the nose and its implications in facial plastic cosmetics. For example, it has a huge implications nowadays in complications of fillers injections in the nose. And I think it is important. So you can see how much the anatomy is linked with the procedures, surgical procedures or aesthetic procedures. So, but our problem nowadays when we are performing rhinoplasty is this one. There are different types of noses, and you know that Asian noses are not the same that the Caucasian noses, that traumatic noses are different from tension noses. So we have to adapt the techniques to the noses. So we have a toolbox and we have to choose the appropriate instruments to modify the nose the patient is showing. And after that, as you may know, it's not only a problem of anatomy, it also depends on the patient expectations. Patient expectations are the key. If your patient is unhappy, even if you have done a fantastic nose, a fantastic job, you will have troubles with this patient. And so we have to take care of these expectations. Surgical procedures, I thought about that, and we are a little bit lost nowadays in the different surgical procedures. And what are we doing in our practice is what we learned during our resident fellowship, and so we are just doing what we learned before. And your history is not only just repeating what you have learned, but asking to yourself, how can I improve my technique? How can I improve what I'm doing? And so the problem is that if you are just following what you have learned, you are always doing the same things and you are not improving yourself. And so all this is nowadays creating a lot of confusion, because when we are going in meetings, sometimes you go out of the meeting at the end and finally you say to yourself, okay, what did I learn during this meeting that is interesting, that I can apply in my practice for rhinoplasty? And sometimes you have a headache and you don't know really what you are doing because you learned a lot of tricks. Interesting to learn tricks, but you didn't learn what is useful in depth for your practice.
Yes.
So what is preservation rhinoplasty? Because Cam, you asked me to talk about that, and to speak frankly, I enjoy that, as you can see, because I know I'm very long, because you told me that I have a little bit time, so I like it very much, because it's
Great.
Really sharing the experience in this way. Thank you very much. But you can stop me, don't hesitate again.
No, carry on, it's great.
So what is preservation rhinoplasty? Preservation rhinoplasty, I said it is a philosophy of rhinoplasty, but it is mainly dedicated to primary rhinoplasties. It's very difficult many times to perform preservation in revision rhinoplasty because things have been already changed. So what preservation means, we have to preserve something. And so we can just perform that if there is something to preserve. So generally for primary rhinoplasty, generates reduction rhinoplasty because it's very difficult to, at the moment, even if we tried in different ways to apply the preservation principles to augmentation rhinoplasty, that is not as easy as it could look from far. And then we have to preserve I told you, the anatomy of the nose. Then, so it's mainly applied to, it depends on the patient selection. And in my practice, I have mainly Indo-European patients and very few Asian, very few patients from Africa. So my personal experience is limited to this kind of noses and this kind of patients. Very quickly, this history, it is not a new one. The high septal strip is from Goodale, end of 19th century, and septal disarticulation was from Cottle, mid 20th century. This is key area preservation. Mm-hmm. And then many colleagues add their names to do these different techniques, mostly in the, till recently in the Cottle's technique adaptation, and now many are talking about the high strip. And so we will talk today, if we have time, about the respective indications. And things changing, things changed after this paper I published in Aesthetic Surgery Journal a few 3 years ago in 2000, and it was end of 17, beginning of 18. Because I was talking with Roland Daniel, and Roland told me, Yves, you should write something about that, because really it looks very interesting now, and we have done, we know what we can do with the structural rhinoplasty, but we don't know what you are doing yourself. And I think what you are showing is interesting. So I published this paper about 540 rhinoplasties, primary rhinoplasties in 6 years, and with about 60% cases of dorsum preservation. Now I'm performing a little bit more nowadays. Mm-hmm. And I was mainly interested in the revision rate, because for me the revision rate is the only true objective criteria of the quality of the surgery. If you are doing truly 10% revision, I think it means that you are a good surgeon. If you are doing 20% revision, I think it's a little bit too much. If you are doing 2% revision, it means that you have a big problem in your evaluation, because it's almost impossible in rhinoplasty to have only 2% revisions in the surgery. This is what I feel in my practice. So, and these were the main motivations for revisions: hand recurrence, axis deviation, a little bit widening of the middle third. So we tried after to improve these complications, issues after preservation. I have almost no revisions for breathing impairment after the surgery. So this was a good starting point. But I would like to say to our colleagues who are listening today, this presentation, is that before starting performing preservation rhinoplasty, first we have to understand the philosophy. If you do not understand the philosophy, if you are trying to make a preservation rhinoplasty with the structural philosophy, of course it will look impossible to you. Then you have to check your anatomy knowledge. This is critical. Anatomic knowledge, you cannot perform good surgery if you don't know this in a good way. Then you have to understand the biomechanics of the nose. The biomechanics is the key, because if you do not want to remove the tissues, but to make changes in their relationships, in their shape, in moving the shape of the bones and the cartilages and the ligaments, you need to understand how it can work. And this is a big change between the classic rhinoplasty procedures and the preservation procedure. That's why I'm talking a lot about biomechanical anatomy. And then, of course, you have to learn the principles and choose the appropriate patient. So I would like to say that if you are a beginner in rhinoplasty, of course, you have to learn first septoplasties and turbinoplasties in order to avoid breathing issues once performing the surgery. But please go to the anatomy lab, attend anatomic dissection courses, because this is critical in your practice. If you are not going in the lab, or you will make experimentations on your patient, and ethically this looks a little bit not fair, or you have to then please go to the lab and check the techniques. Then you have to assist, of course, experienced surgeon, learn step by step, and go back again to the anatomy lab. I can tell you that every year I'm going to the anatomy lab because I need to understand some steps. I need to understand what is happening. I need to understand how it works with the ligaments, how it works with some variations of the key area, the relationship between the cartilage and the bones. And so we have to understand that, because otherwise we will have some bad issues sometimes, and we do not understand why we have these issues. So please go to the anatomy lab. This is the key of the success in rhinoplasty in general, not only preservation, but in rhinoplasty. So this was for the beginners, but if you are already an experienced or even an expert in rhinoplasty surgery, please, if you want to perform a preservation rhinoplasty technique, I would like to say, do not commit the sin of pride. I did that because I said, after my first article, I said, okay, I'm very brave now. I have done hundreds of preservations, so I can do whatever I want, and it will work very well. It is not true. It is not true. You have to be very humble in rhinoplasty. I say that rhinoplasty is every day a lesson of humility. You can have 10 fantastic results, and suddenly the next one will be some very bad experience, and you do not understand why. And this is interesting. But so, if you are experienced, please just think about that. Do not commit the sin of pride. Stay humble. Read the books. We have written the book just for avoiding big issues with that, bad issues. And again, even for the experienced, go to the anatomy lab and check how you can apply your knowledge to the techniques. Then learn how to choose the appropriate patients. I will try to help you in this step, and of course perform each step incrementally. Go step by step. Don't try to switch one step to go directly to the next one, because you will have bad issues if you are doing that. And of course you need to perform some understand how once you are making the osteotomies, you are really handling the nose in your hand, and it gives at the very beginning a very special let's say like abnormal feeling of moving the nose, like if you were moving something like an apple in your hand. I mean, it's very, very special being able to move the nose in this way. So in rhinoplasty, Cam, do you want me to go on, or do you have questions?
Carry on. No, this is great.
So one of the questions that was asked to me many times, and it was asked when I was for the first time invited to the American Academy of Facial Plastic Surgery. The first question people ask me is this one: how is it possible to make the nose smaller without resecting nothing on the dorsum? It looks no more than strange. It looks like almost impossible. So I had a discussion with very famous surgeons, and at the end of the discussion, I told them, if you say I am a liar, that what I'm saying is not possible, please come on the operating room. I will show you how it works.
Yes.
But yes.
No, carry on. Yeah, I want to hear this.
Okay, sorry. Okay, so it looked so strange that people could not understand, even experts in rhinoplasty. So I like showing this. I can show only the photos of patients who agreed to share their photos. So that's why sometimes we are showing the same photo because it's very difficult to change for every presentation all the photos. It's almost impossible. So this is a patient. She has very. I will come, if you allow me. I would like to introduce some other concepts, not only preservation, but how to evaluate the nose in the face.
Yes, please. Yeah.
So look at this lady. Very nice eyes, nice mouth. But what is, that in communication, in our in current life, how our behavior, we are just looking at how people are looking at you and how people are smiling to you. And we are not communicating with our nose. We are communicating with our look and with our smile. And we can consider that let's say, previously we said the fixed nose. Let's say the bony cartilaginous pyramid, that nasal bones and upper cartilages and septum are directly related to the look, to the eyes. So we can say that this is the looking or the nose of the look. And there is also the nose of the smile, that is the tip of the nose and the nostrils. If you follow the nasolabial fold, you can see that the nasolabial fold are making like a round shape all around the lips, but also around the nostrils and the tip of the nose, nostrils and tip. So we can consider that in a way we have not one nose, but we have two noses in communication. We have the nose of the look and the nose of the smile. And when we should not see the nose when we are looking at the patient. So coming back to this patient, if we look at her face, what we can see her look and her smile, but something is not going well here. Something is wrong in the middle. And because the nose is not nice. So we see the nose as the third target of our look, how we're seeing her. But once you have making the changes of the nose, then you forget the nose. And what do you see? You see just how she looks at you and how she smiles at you. So the nose, you forget the nose. And this is what we can call a successful rhinoplasty. A successful rhinoplasty is the rhinoplasty when you forget the nose. You just see a nice look and a nice smile, and the nose is forgotten. And for me, this is my main criterion for a successful rhinoplasty. Do you agree with that, Cam?
Yes, but I've never had it explained like that to me before. And it just makes so much sense that we've got two noses. That I'm going to look at people very differently from now on.
You will see. And if you have the opportunity to come in this, if you are lucky, I will explain that more, that how we can use this expression of the face, I mean the look and the smile, in the evaluation of the rhinoplasty procedure. So let's go on. And so this is this lady in profile view. She had let's say deep radix and witch nose, because it's like a witch nose, with long nostrils. The nose is going downward. And what I performed is really a preservation rhinoplasty. And surprisingly, the radix looks higher, but the radix is not higher. What changed is just the dorsum and the size of the nostrils. And then she wanted a pretty high tip, over-projected tip, so it's what I performed. And look on the oblique view, we completely forget the nose. We see a very nice look, including the nose of the look, and we see a very nice and let's say a sensual lip, including the nostrils and the tip. And this is critical. When you forget the nose, it means that the rhinoplasty is very successful. And if you look before the surgery, the nose is visible. If you see the nose, it means that there is something wrong on the nose. But if you look carefully, you can see that the makeup is exactly the same before and after. What is changing is only the nose, nothing on the lip, nothing on the look, on the eyelids, nothing on the makeup, just the nose. And so in the post-op, we forget the nose. And this is, in my opinion, the best criterion. Let's look now at this lady again. This is the pre and post-op, and you will see that the makeup is exactly the same before and after, except the skin. This was in summer, this was in winter, so the skin is tan before and pretty white after. But anyway, so what changed after the surgery? The look looks a little bit more kind, but she has big eyes, so it didn't change a lot. But we can see better her lips and her smile. And this is very good, even if the nose is nice. So in profile view, I could erase the hand by making the preservation rhinoplasty. I did not change the radix, but I could really lower the dorsum and change a little bit the orientation of the tip, just making it a little bit up in order to get these lines in the nose of the smile. And if you look carefully at the nose of the smile, if you look at that very carefully, I like to say that I don't like measuring the angles on the face because I'm not able to measure angles in the face when I'm performing a rhinoplasty. But what I can see is that I can see the upper lip when I'm performing the rhinoplasty, and I can see the edge of the nostril and of the columella. And on profile view, these lines, the upper lip, the columella, and the edge of the nostril the three lines should be parallel, mostly parallel. At the moment, the nose, let's say the columella line is crossing the upper lip line, then the nose looks long. It is an optical illusion, but it gives this sensation because again the tip and the nostrils are belonging to the mouth. It's the nose of the smile. So in the post-op, I just look at that. I just change the position of the tip, and now look at the direction of the lines. The columella line is parallel to the upper lip. So the nose does not look like going to the tip, it's not touching the lip. It's really parallel to it. And for me, it's critical to understand that these lines are parallel. It's very easy in your practice, even during the surgery, just to see that. I never measure the angle. It can be 90 degrees, it can be more, it can be less. I want my nose being parallel to the upper lip. So this is the 3/4. Again, we've completely forget the nose after the post-op. It is very natural. We see a little bit better the lips and the smile, and we see much more the eyes. And I remember Jean Tardy talking about look at her eyes when he was showing his presentation. And I do agree with Jean Tardy was saying at this time. And on the 3/4 oblique view, the nose is hiding the eye. It should not hide the eye. It should just be like this, and we forget the nose again. And this is a very natural. And right in preservation, we can really give this kind of result because you have no surgical look in this area because everything is really natural. And of course, we can change the shape of the tip. In this case, I made sutures in order to make, because she had a square nose, I wanted it to be triangular, just by suturing it. Before surgery, I told her, probably I will have to change your nostrils. But once I did that, the nostrils, I didn't do any procedure here because they look pretty well, pretty good. So no need to perform any nostril procedure or allied basal resection or whatever. So, Cam, I'm sorry I bothered you with this kind of concepts or the nose of the look and the nose of the smile, but I think it's very important in our practice. It's not. Of course, we are a little bit far from preservation rhinoplasty, but I think it's very important in our practice.
No, that you got to get these foundations right. So, an interesting thing you said there was that you don't really want to take too many measurements and angles in your surgery. And to me, it's always, there's a difficult balance to get right where I remember Lissandra said on the podcast a few months ago how there are many roads that lead to Rome or many roads that lead to Nice. But some guys are pedantic about measuring everything the whole time. And then on the other side, it's people who almost like, they have this artistic part to them that they know what looks good on that person's face. But to get the balance right between the two is not easy.
Yeah, because it's Michelangelo said the compass and the rule are in the eyes. So it's true. It means you are using your eyes, and your eyes just give you the feeling of what is correct or not correct. And but the thing is, with when you want to write a paper nowadays, you need to make measurements, angles, distances, millimeters. And we can do that. I think it's important, but it's not the only criteria of quality or beauty.
Absolutely. Yeah, great. Carry on, eh? Question 2, how does it work?
Yes. So now going with the biomechanical anatomy. I said just before that the biomechanical anatomy is very important. So we need to understand what is happening in the nose. When we do not resect, we just change the aspect. So I would like to go back to the anatomy. And so these are dissections I did 20 years ago, but I like them very much. So this is the profile view and front view on 2 different specimens. So there are some areas that are critical. There is the lateral wall and the dorsum. On the dorsum, the key area, you know this very well, I will not be too long with that, there is key area is the characterization is the overlap between the nasal bones, the septum, the quadrangular cartilage, and the upper lateral cartilages. So this corresponds to the key area that is one of the critical area for the aesthetics of the nose. And this is the scroll area. It was very interesting when I described that more than 20 years ago. Interesting to see that the scroll is really the way how you can pull the nose downward or upward and push. If we didn't have this kind of scroll in this area, we could not change really the shape, elongate or make the nose shorter, because this really works like a spring effect. This is like a spring. So, or scroll area. So looking now laterally, there are four very important structures that are the Webster triangle, where we can say that the Webster is pretty down. It's very close to the end, to the end of the accessory cartilages laterally. A little bit up, we will find the piriform ligament that is attaching in a way the lower lateral cartilage to the peripheral aperture. A little bit up to the piriform ligament, we will find the lateral key area that is a little bit at the upper part of this, because this is not perfect, it should be a bit higher. That is critical in the preservation rhinoplasty procedures. And please do not forget the attachments of the medial canthal ligament on the frontal process of the maxilla in this part of the nose. Because, okay, if we do not want to change the radix, then we do not touch the medial canthal ligament. But at the moment we want to move the radix downward or upward, these attachments are very strong attachments like a tendon, and you have to undermine this tendon if you want to move the radix to get a nice result. And in front view, look at the anatomy of the dorsum. It is a fusiform shaped dorsum. It is not parallel. The parallelism of the dorsum lines is directly related to the soft tissues, because soft tissues are thick at the radix area and are thick at the level of the lower lateral cartilages, but are very thin on the key area. So these soft tissues are transforming a fusiform shape of the bony cartilaginous structure in parallel lines that we call nowadays dorsum aesthetic lines or Sheen lines. So it's important to understand that. So if at the end of the surgery, I can see many colleagues saying, okay, now during my surgery in open approach, I have parallel lines, the nasal bones are parallel to my upper lateral cartilages, and so on. It's wrong, because you will have issues with the shape of the nose, because it should not be parallel. It should be fusiform, and the soft tissues, if you do not change the soft tissues, will cover that and creating the dorsum lines. So this is a fusiform shape of the dorsum. It's not, and you know, I will be a little bit quicker now because you know that very well. This is, I published that 15 years ago in the Black Book of Anatomy. Look at how high the septum is going under the radix. The septum is arriving here, and how high the upper lateral cartilages are going under, deep to the nasal bones. And this creates the overlap that is the definition of the key area, dorsal key area and lateral key area. So this is just the dissection I did 15 years ago to show that. So how can we act on this area? We have two options. Or we perform the high septal strip, or we perform the low septal strip. And then from these two basic techniques, there are many variations. So let's start with the high strip. High strip is very easy to understand. You have a hump, or you have a dorsum, and you want to lower it, or you want to make it straight. So you create a space just underneath this dorsum, and so you will be able to drop or to push the dorsum in this space you have created. And depending on the height of the septum, that is on the midline, that is the pillar of the dorsum. Depending on the height of the septum, you will be able to lower or incrementally the dorsum and the key area downward. So if you are not performing an excessive reduction of the septum immediately during your surgery, then incrementally you will be able to lower the dorsum till you are arriving to the precise level you want to be. And then you fixate the dorsum in this place, and then you can achieve the profile you like. So it makes the preservation rhinoplasty with a high strip a very predictable technique. Even if you can have some problems sometimes, the good thing is that it is very predictable. And today we will not have time to talk about the problems of the radix, but anyway, if you are performing the appropriate technique, you will not have any problem. And it works like this. So you press and it goes downward.
Beautiful.
So Cam, is it okay? Can
Yes,
go on?
Yes, yeah. Please continue.
So this is the principles of the high strip. You are creating the space just below the bony cartilaginous vault, under the nasal bones and under the upper lateral cartilages. You are acting on the nasal septum, creating a space here. And then when you will have performed the osteotomy, you need to cut the bones. Otherwise, of course, you will not be able to push to change the shape of the bones. And then you will be able to lower the dorsum. This is the principles of that. So you have a triangle. I explained that to my patients. As we are in France, I told them, okay, let's consider this is the Eiffel's tower. You want to have a smaller Eiffel's tower. What do? You have two options. Or you cut the roof or the tip of the tower, and then you will have no more a tower. You will have something flat on the dorsum, and you will have to rebuild a triangular shape of the tower. Or you want to make the tower a little bit smaller, so you just cut the feet, and then you can lower the tower, and the shape of the tower is exactly the same before and after. You just make it lower, keeping the same shape. But intraoperatively, if you want to make this tower smaller, then you remove a little bit more of the septum in the midline, and so you will be able to lower more. So resecting more septum gives you the opportunity to lower intraoperatively more, to lower more of the dorsum. So this is the triangle of the nose. If you push down the nose, then you will have the triangle is going inside the nose here. So the blue is the facial plane. Of course, sometimes we can remove this excess of bones laterally. That is called the let down technique. Or if you have to lower less than a few millimeters, then you can just press it, push down, and the bones there will be a lateral overlap. That is also helping in the stabilization. And so this is the principle. So you lower, but at the same time you are lowering the dorsum, then you can see that this triangle, the base of this triangle is smaller than the base of the previous triangle because this is the basic geometric shape. So at the same time that you are making the nose smaller, you are making the nose more narrow. And this is normal because it is the anatomy of this one. So regarding what is happening upward now, I call the coat hanger effect. So this is the coat hanger, so you can hang your coat on that. Why is it stable? Because you have this strut that is keeping the shape of the coat hanger in good place. If you want to change the shape of this area, then you need to remove that. Otherwise, you will not be able to flatten that. And this is what we are performing when we are resecting the high septum in this area. Then you are removing this part that is blocking completely the movement downward, and that is blocking the flattening effect. And then once you have cleaned what is below the dorsal the dorsum, bony cartilaginous vault, then you will be able to flatten it or even to curve it more if you want to do that. So just remove what is blocking, and then you will be, if you remove the strut, then you'll be able to flatten the dorsum. When we look in the anatomy, because I said, as you know, anatomy is the key of the understanding. So this is I removed the soft tissues, and I made the complete osteotomies, lateral, transverse, and radix osteotomies. I have removed part of the septum inside. And then am I able to press, and what is happening? So I'm pressing on that, and we can see that the dotted line is really arriving at the level of my cut. So I have, in this case, I lowered about 8 millimeters. So it gives this kind of shape of the dorsal. So we can really lower that. And what is happening at the internal nasal valve when we are doing that? So this is the upper lateral cartilage. This is the septum. You remove a part of the septum here, that is the high strip. So and then you press. What is happening? So you are pressing here. This is the cut, and the internal nasal valve is opening because the angle will change. So you are opening the internal nasal valve when you are pushing down the bony cartilaginous wall.
Okay, so I want to ask two questions there. I understand that you actually answered the first question about the nasal valve opening more as you push down. The other question that I have, though, is the nose looks so unstable because you've now cut through the bones laterally and you're pushing the nose down. Yes. What keeps it in place? Is it only where you are re-approximating the septum, where you've taken that septal strip away? But are you also trying to do something to keep the bones in place on the lateral aspects or not?
Thank you very much, Cam. Yes, this is one of the critical questions of the stability of this technique. The stability is one of the key of the success. So we want to, once we have made the movement downward, we want to the nose keeping the same place. So we have three areas where we can fixate the position. Laterally, if you have done push down, I mean just by lowering this downward, then you will have an overlap. So there will be friction. You will have a bone-on-bone area that is a little bit blocking this area on the side. This is why in small hump less than 6 millimeters lowering, I prefer the push down than the let down, because the let down you have no stability laterally. So I prefer this. So the overlap is giving a lateral stability. The second is on the midline. I said that we need to lower the upper lateral vault on the septum. To do that, we need to suture it, and the suture is one of the key. Also, you can do this directly from inside, or you can do that through. If you are performing an open, then it's better because you can fixate not only the cartilaginous vault but also the bony vault to the septum. So we have these points of fixation are on the septum. Better to have 2 points of stability here using sutures. And you have laterally, it's very difficult to use things to stabilize laterally. Of course, we can insert some fragments of bones in the fracture line laterally to make it more stable, in the same way that we could do that when we are performing some works at home. But generally, we don't need that. But it's possible to use some fragments of bones or cartilage to fixate laterally also that. Is it understandable, Cam?
Yes, thank you. Yes.
Okay, thank you very, very much. So this was the high strip. The second technique is the Cottle technique, and there are a lot of technique variations coming from this one. But what is interesting is this one. Look at this. You have this is let's say a pension nose. How to make it flatten? Then you resect, as I said previously, the coat hanger effect. So you resect the septum below this, and then you are able to lower it by pressure. Or you can just divide completely the cartilaginous septum from the bony septum, and then you are able to open this angle. I like calling this action the distraction. It is a true distraction of the cartilaginous. The quadricular cartilage from the bony septum. So it is a distraction. So you are creating an angle inside, and once previously it was closed. This is natural septum, bony cartilaginous junction, and then when you are separating, you are creating this angle at the level of the opening in this area. So then there are variations. So Cottles is doing that. Let's say variation can be whatever the name we give that. We can be SPQR, we can give different names, whatever the name we give, the spirit is the same. You need to separate the septum vertically in order to being able to turn, to pull this anterior. You want to make a distraction to open this area. So by opening that, you will lower the vote and make it straight, because as you are pulling the septum anteriorly, the vasa segment and the upper part of the segment will go up, and then you are lowering this part, but you are making this part going up. Mm-hmm. So at the same time, you are reducing the height of the hump, but you are also feeling, in a way, and this is very interesting in some kind of noses, you are feeling the supratip area, and you are also opening the nasolabial angle, because the septum is going in the nasolabial in front of the nasal spine. So it is very interesting in deep nasolabial angles and like subtle deformities, because it's a very powerful technique in these cases. But the weak point of the Cottos technique is that you have only very few points of fixation, mainly at the level of the anterior nasal spine in this area. So we have mainly one point of fixation. Carlos Neves improved that, performing his Tetris technique, but I think he will talk probably with you. But because as he keeps the lower part of the septum safe and stable, then he makes multiple points of fixation, making the Cottos technique much more powerful and stable. So the second part that is interesting is the predictability. So this was a lady. She's coming from Sweden, asking for preservation rhinoplasty. She told me, my nose is not that bad, but I want to improve that. And could you make it better with just your technique? I told her, okay, let's try to make a computer simulation. This is the computer simulation of her. So this is at the beginning of the surgery. So this is the same lady with a little bit starting point also of Chinese hat laterally. And once intraoperatively at the end of the surgery, while I have done my procedure, you can see that we are exactly on the computer simulation and that the Chinese hat is also closed. So it's very predictable technique and very low risk surgery. If we are thinking about the post-operative period, I would like to say that the most powerful technique, the most important difference between the preservation techniques and the other techniques is that if you have a revision, the revision will be very easy after preservation, as it will be more difficult after the other techniques. And my time of revision is about 23 minutes after a preservation, while it is generally more than 2 hours, sometimes 4 hours after other techniques. So for the same result, even if we can say in a way that preservation could not give better results than the other techniques, but if you have 10% or 20% revision rate, this revision rate will be your patient will be much more easy and happy after surgery, because we don't need to perform any harvesting of the rib. You will just need to reshape the nose again. So this is the big change and the big advantage of the preservation regarding the other techniques, is that really it's very safe technique with good results, even if it is not the best technique in all cases. So the step by step, I will be a bit quicker, otherwise you will spend all the night with me. So we'll talk mainly about the dorsum. So there are different steps. So it can look a lot of steps, but in all techniques, if you are taking account of everything, you will have many steps, whatever the technique you are using. So these are different steps. I will not be too long. I would like just to say that if you want to perform a preservation, you need to separate the nose from everything. So you need to separate the nose from the septum, from the face, from the skull. Then once you have separated the nose from this septum, face, and skull, then you will be able to perform safely mobilization, and then you will go on with the lowering, alignment, harmonization, all the other procedures. But remember, look at that. The first structural surgical step is the separation from the septum. Because if you are starting with the osteotomies, separating lateral osteotomy, transverse osteotomy, and you start mobilization and you forget to separate from the septum. Then you will really shake the septum, not only the cartilage in the septum, but also you will shake completely the perpendicular plate of the ethmoid, and then you can have some troubles with the skull base. So just remember that one of the very important first steps will be to separate the bony cartilaginous pyramid from the septum. And if you hear colleagues saying that they first do the osteotomy, then they do the septum at the end, remember that it is pretty dangerous. So separation from the soft tissues, this is anatomy because it is easier. Just check the caudal edge of the quadrangular cartilage, the anterior septal angle, and if you pull a little bit more with a retractor, you will see what I call the W point. That is the junction between the upper lateral cartilages and the septum. That gives a W shape. And in France, we call this point the plicanesi. Plicanesi in Latin means, plica means the fold, and nasi, the nose. Fold of the nose, so it corresponds to this area of the nose, the junction between the upper lat and the scroll area. Plicanesi, anterior septal angle, and W point. Then generally I perform always a vertical incision. I never go laterally in an intercartilaginous. I never go intercartilaginous incision. I'll always stay vertical, following the caudal edge of the septum till the anterior septal angle. So I really preserve completely the attachments of the upper lats to the lower lats, and I don't touch at the lateral scroll ligaments. Then, of course, you perform pericondylar undermining. You find on the dorsal line, this is the anteroseptal angle, this is the W point, and this is what I call the vasa segment between the W point and the anteroseptal angle. And this vasa segment should measure about 1 centimeter, 10 millimeters. Sometimes it is very short. It is 1 or 2 millimeters. In these cases, you need to cut to separate the upper lats from the septum till you will have about 1 centimeter length. Otherwise, the cartilaginous bridge will stay too wide, and it will be almost impossible to make it more narrow at the end of the surgery. So you need to divide. And remember, the measurement of the vasa segment should be about 8 to 10 millimeters length. And then you will avoid a lot of widening of the middle third. And as you can see, once you have done that, you can see the caudal edge of the upper lat that is arriving here, creating this W point. And so you can also remove this part of the end of the upper lat in order to make the supratip area and the cartilaginous vault a little bit more narrow if necessary. It does not have any impact on the function because you are completely preserving the vault of the cartilaginous vault. So this is W point. Then you perform your elevation. I go quickly now. And then the separation, I always start my separation. I perform the undermining on both sides. So I'm creating a superior tunnel. And the height of my tunnel should be a little bit more than the height of the reductionary plan, because I need to free the cartilage as high as I need. For example, if I need to lower 3 millimeters, I need to undermine 4 or 5 millimeters. But if I want to lower, like today, 1 centimeter, of course, I need to undermine at least 12 millimeters. It makes at least 2 height of your elevator, 2 heights of the elevator. So this is the tunnel on the right and on the left, of course. And then you start cutting at the W point, the junction between the upper lats and the septum that is here, in order to be able then to lower what is up. And after the surgery, at the end, you will decide what to do with the vasa segment. Because if you start with cutting here on the caudal edge, many times it ends up with a saddling of the middle third of the supratip area, because this is really going down very easily. So please don't start here, start always at the W point, even if you have done previously a separation of the upper lats from the septum, just to make the length of the vasa segment about 1 centimeter. Then you can check with your elevator, going from the right tunnel to the left tunnel once you have cut the septum. And then if you are being to to pass your elevator from the right side to the left side and from the left to the right, it means that you have completely separated the cartilaginous septum from the bone, and then you will have to separate from the perpendicular plate of the ethmoid many times because you need to free that. And I can tell you that this is really not dangerous. So this is the shape in anatomy of what we could have. So this is the caudal edge of the septum. This is the anterior septal angle. This is the W point. This is the vasa segment that is not untouched at the moment. This is the resection I have done under my cartilaginous and bony vault. And then I have created this space. And in this space, I will be able to lower the dorsum. And this is in surgery. In this lady, I remove the cartilaginous high strip and together with the perpendicular plate high strip. So it was a very easy one. So you can use whatever the instruments you like, and you can achieve this kind of resection. Generates about 25 millimeter length and about 3 to 5 millimeter height, a little bit triangular shape, and then you are safe. I can tell you that even if you remove completely the perpendicular plate under the bony vault, you will not end up with a radix lowering or with a saddling nose, because the cartilaginous vault will be stable, and because the cartilaginous septum will be stable, and you have, remember, the lateral points that are the lateral tendon, medial canthal tendon attachment, that is, say, the overlap between the bones laterally that are safe. So you will not end up with radix deepening if you are not making some errors laterally in this area.
Okay, so a quick question that I have there is, now when you've removed the septum, so if you are imagining that the septum sitting with the upper laterals on either side, how high up do you go unto? And because you surely have to leave some septum most superior to be able to still put a suture in to pull it back down.
Yes.
So
yes.
How much are you leaving of the septum underneath the dorsum, as it were?
Yes, it is very important. If you want really to be able to flatten the bony cartilaginous vault, if you transform it from convex to straight or even curved, then you need to remove all the remnants of the septum, cartilaginous and bony septum, just below the bony cartilaginous vault. Otherwise, the fragments you have left here under the vault will block this flattening system. This is critical under the key area, except if you are performing like Kovacevic or Neves, or if you are separating the cartilage here completely from the bony vault, then you will be able to, by pulling this cartilage downward anteriorly, you will be able to flatten. But generally, if you want to perform a correct high strip technique, you need to clean very seriously everything that is underneath the bony cartilaginous vault. Otherwise, this will be a blocking point, and you will not be able to achieve the result you are expecting.
Okay.
And to do that, I'm using this instrument that is straight Black-Esley forceps that we use in endonasal surgery. It is very common forceps and very easy to use. And then you can clean with this. Even if you don't see what you are doing, just insert this Black-Esley forceps below the vault. Then you use this like a ronger, and with the left finger you are touching the external nose, and with the right hand you are removing the remnants, and it's very easy, safe, and very quick procedure. And then you will keep on your table the fragments of cartilage, because there always stay some cartilage fragments here, to use them if necessary to make some camouflage. Sometimes it will be like a starting point of diced cartilage. So then you need to perform the lateral osteotomies. They can be percutaneous. Be careful with the Webster's triangle, or they can be also endonasal. You know that very well. If you want to perform a let down technique, I have done this afternoon 2 let down techniques because I had to lower my patients more than 8 millimeters lowering. Then I undermine from endonasal. I undermine externally and internally the lining. And then with my bone ranger, I remove about 5 millimeter height of the bones, like the starting point of my lateral osteotomies. So then transverse osteotomy, to speak frankly, it is so easy to make it percutaneously that, okay, we can use whatever the saw or the piezo, whatever the instrument you want. But many times in the preservation rhinoplasty, in straight noses like these ones, you don't need to elevate the soft tissue. So if you do not elevate the soft tissue at all, I mean, you do not elevate soft tissue at all, not on the dorsum, not laterally, how will you perform the osteotomies if you want to preserve all? You cannot. So this is the power of the percutaneous osteotomy. You can completely separate the nose from the face without elevating the soft tissues. But so, and another good reason to do that is even if you are performing the classic rhinoplasty techniques, then sometimes you have like a blocking effect here, lateral at the level of the radix, and this blocking effect can be cut very easily, but with using a 2 or 3 millimeter osteotome percutaneously. Otherwise, you will spend I don't say hours, but you'll spend a lot of time trying to make the correction of this rocker effect at this area. So this is the radix osteotomy, and so at the end you will have this kind of osteotomy, lateral osteotomy, transverse osteotomy, and radix osteotomy on the top. Then you will be able to make mobilization, right, left. It should be very easy to do. If you have some resistance, just go back to the osteotomy and check what is blocking. And then you will be able to move the nose in this way, to the right, left, to the right side, to the left side. Don't try to push directly the nose downward. Just remember that you will be able to push the nose once you have made complete mobilization and you have removed part of the septum below. If you are not doing that, then you can be in trouble with the perpendicular plate, and it will block. So this was a patient. This was before surgery, almost straight nose, and deviated, with a lady about 20 years old. I have done this recording when Roy Dalino was in Nice. It was in 6 years ago, more than 6 years ago. I wanted to show him. And so I performed this. So the septum has been already done. Then I'm performing the osteotomies, endonasal lateral osteotomies. And then I will perform transverse and radix osteotomies. Transverse and radix osteotomies. I always add some drops of adrenaline to reduce the bleeding, because bleeding is always unpleasant for everybody. Then you use this 2 millimeter or 3 millimeter osteotome in order to separate the bony pyramid from the skull, and then you are really separating completely, going downward in the direction of the medial canthal ligament and going upward in the direction of the radix. And if necessary, then you can cut the radix, and then it's done. You have completely separated, and then you are able to move the nose right and left, and then you pinch a little bit downward, and you can press, and the nose will go downward. So when you do that, you are narrowing the bony cartilaginous load because you are pinching a little bit. And this is the aspect after the osteotomies and the septum. And if you remember, she had the deviated nose and wide nose and straight on the profile. And this is at the end of the procedure, a very nice narrowing of the bones and straight nose. As you could see, the procedure was about 30 minutes. So it's a quick procedure. Of course, you need some experience. And this is the shape. So this was just to show. And this in deviated nose, for example, you can have this kind of cone beam after the surgery, showing that you have an overlap laterally between the stable frontal process and what you have cut, while on the other side, you don't have any. In deviated nose, I repeat, deviated noses, you make a tilted nose on the side, and then you have performed the transverse osteotomies and radix osteotomy to perform the complete result. So again, this is how we perform that, and then you lower. This is intraoperatively the level I decided for this lady. This bump of the supraarticular corresponds to the vasa segment. This was my W point, and this was my anterior septal angle, and then I will have to adapt. This is the endonasal view. This is my anterior septal angle, vasa segment. And using this Aufricht elevator, I can put this Aufricht elevator under, just below, this is my septum, so I put my Aufricht in my septal access, and then I can pull up my bony cartilaginous pyramid, and under direct vision, I repeat, under direct vision, without headlight, without endoscope, you see the uppercut of your septum, and then you can adapt, cutting incrementally 2 or 3 millimeters till you are arriving to the correct level. And then you can, under direct vision, cut 1, 2, 3 millimeter, like many strips. This one is about 2.3 millimeter length and about 3 millimeter height. And this is the aspect at this step. And then if you check, then look at that. I have removed about, let's say at this step, 5 millimeters height. But once I have done the osteotomies, look at that. The W point is again on my septum. So, Cam, to answer your question, then you can make a suture here. And then you have fixed the W point on the septum. So you have a new dorsum. This is the septum. This is the anterior septal angle. This is your W point. You fix it here, and you have a complete natural septum, like untouched septum. So when you are making a revision, then what do you see? You see that. You see like an untouched nose. It's very funny. And so if you want to lower, okay, you can decide whatever you need. But you are really in this way. And if you are a good surgeon, you have done a subpericondyal dissection. So going back to the septum is a very quick procedure. And then making this, it takes very few minutes to do that. So you can really adapt. But this low suture at the level of the W point is not enough. We need to add a higher suture at higher point to really make the stabilization of the head of our dorsal. So this is the intraoperative view using an endoscope to show. So there are the subperitoneals. The first cut at the level of the W point. You can recognize the upper lateral cartilages that are here. And, excuse me, I can step back. So this is the left tunnel, this is the right tunnel, supericondyal. Then I start my cut just at the level of the W point. This is my cartilaginous vault, and at a higher point, my bony vault. I cut here, and I will try to stay very high under my vault. You can see that I cut till I'm arriving at the level of the bones. And then I will use, this was live surgery done in Istanbul a few years ago, probably 3 or 4 years ago. And then I had to remove my strip, my first strip. That was pretty big in this case. You know, in live surgery, so it's a little bit more stressful for the surgeon. So, but anyway, it worked well. So I was using this kind of scissors that we use generally for the, and you can see that how long high is this fragment, about 5 millimeters height, and a little bit, almost 3 centimeter high. And this is intraoperative, the drawing of the lateral osteotomy and the entry point of the transverse and radix osteotomies. Let's go on. Then if really we want to curve the dorsum, because many patients, ladies, are asking for curving the dorsum, then we have to do some steps. Remember, you have to undermine the mucoperiosum under the vault. You have to remove the strut, the remnants of the septum below the vault, what I call the coat hanger effect, in order to be able to curve the dorsum. And then what do you want to do is to avoid that the hump comes back, like pop effect or spring effect. And to do that, you will have to deal laterally with the piriform ligament or with the lateral key area in case of tension noses. In straight noses, it is not necessary, but in tension noses, it's necessary. So then you will have to adapt the middle third. Look at that. This is, again, the W point. Then you will sometimes need to resect this caudal edge of the upper lats in order to reduce the volume of the supratip area. Generally I use converse scissors for that. This is intraoperatively. This is the vasa segment. I'm making sutures in this area between the upper lateral cartilages and the septum in order to have a new normal junction between the septum and the upper lateral cartilage. And then I will put another one at a higher point or crisscross on the bones through an open approach, following the technique that Sebastian Hack and Wolfgang Gubisch presented. That is very interesting technique. Or through the percutaneous technique, like, for example, Dogan presented in his techniques. So this is just to show again the anatomy. This is the resection of the high strip. We have clean below the vault. This is the location, the former location of the W point. Now the W point went down in this point, and this is the vasa segment, anterior septal angle, W point, and then you will adapt the height of the segment according to the appearance of your middle third and the appearance of the supratip area. So this is, and in this case, I decided to make a very easy tip rotation using a tongue and groove technique. So, are you tired?
No, Yves, it's so interesting, but it kind of turns the whole thing upside down. I mean, I just think, what have I done all these years? And I see this, and I see how fast and efficient the operations are. And, you know, the thing that amazes me doing these rhinoplasty podcasts, I just think, like, yes, you guys are good at what you're doing. What am I doing? I'm not doing rhinoplasty. I'm a kindergarten compared to what you guys are doing. So no, it's so good, because I think the guys who in this and are very experienced are learning, but also the beginners can learn. So no, this is the important, very important slide, I think, is how do we actually decide about what to do? Who's the patient to actually make this decision on?
Yes, thank you very much. Yes, it is true that it is difficult to know, because, as I said in the introduction, we nowadays we see so many techniques, so many publications, so many presentations, that again we are a little bit lost in how to choose the best technique for our patients. So in France and also in South Africa, you have to decide which kind of wine will be the best for the meal you have decided to eat. So if it is fish, you will use pretty white wine. If it is meat, you will choose a red wine. And if it is a very strong meat, you will choose a very strong wine. So in rhinoplasty, it is the same. Depending on the nose you have to deal with, you will have to choose in your toolbox the best technique. So I try to made it a little bit clear. So in planning a patient, when I'm visiting a patient, one of the question I always ask myself is: the patient in front of me, is he or she a good candidate for preservation? So, and then the next question that is coming is this one. Okay, what can I preserve in this patient? Am I able to preserve the shape of the tip? Am I able to preserve the middle third? Am I able to preserve the bony vault? And this will be one of the first decision stage. So the second question is the tip surgery mandatory? Today, this morning, I have done a rhinoplasty with endonasal rhinoplasty without any tip surgery, because it was absolutely useless. So why to perform an open approach, degloving everything, if you have no tip surgery to perform? For sure, if you do it open, you will have the temptation to perform sutures and modifications and so on. But patients many times love their tip. They just want to make the nose smaller. But they don't want any tip surgery. And I will show you some patients without any tip surgery. So in these cases, we have to perform an endonasal approach. And I don't want to say that we have always to perform an endonasal, but let's perform an endonasal if there is no tip surgery to perform. Then how is the septum? Will the septum require any septoplasty? Yes or no? If it requires a septoplasty, will the septum be stable at the end or not? How is the peripheral aperture? This is a critical evaluation. I think very few people are evaluating the peripheral aperture. But once you are inserting your speculum in the nose and you open it, you have to see the distance between the inferior turbinate and the lateral wall to the septum. If it's very narrow, for sure you will have breathing issues, and you will have to open your peripheral aperture. But in very wide noses, like African noses, for example, you don't need to worry about the peripheral aperture because it's already wide in most cases. Then it's not the end, because you have to evaluate the upper lip, you have to evaluate the chin, and you have to perform some upper lip procedure. You have to perform any chin procedure intraoperatively or post-operatively. And this is during my first visit. Then generally I am asking my patient to perform a cone beam to check if there are some, we can have some deep problems, what is the thickness of the bones and so on. And then I perform my computer simulations and some measurements. I will be a little bit quicker on this part. So, as you have understood, the selection of the patient is really essential. And we have, so I decided, this is unilateral decision. It is my way of thinking to make a classification in 4 types. The straight dorsum, and you will see that I have many straight patients with straight dorsums, tension nose, kyphotic nose, and the ones who are not straight, not tension, not kyphotic, that I call difficult noses, where I cannot perform any preservation. So I, as I said before, I had done a previous study was on let's say more than 300 patients, and this one is also more than 300 patients, 352 exactly. And so I checked this. So it makes, taking in account the first and the second study, it makes all included 372 patients with consecutive primary rhinoplasties with the same surgeon. That is interesting because it is always the same surgeon in occurrence. It's me, but anyway. And so after that, we have taken the time during the last COVID period to make guidelines. With Sylvie, we have taken more than 1,000 hours of work, each of us. It makes 2,000 hours of work to check all our patients, the photos before, the photos after, the surgical procedures, the revision, what happened, and so on. And so we could say that. And I would like to share that with you. We published that in Facial Plastic Surgery because Jose Carlos Neves asked us to write something in this review where he was the guest editor, so we did that. And so we did this study. I will like to share a few results with you. So we decided to make this classification on profiles: straight, tension nose, kyphotic, or difficult. And the surgical procedure in preservation or in primary rhinoplasty, like full preservation procedure without any undermining, or preservation procedure plus resurfacing of the bony cartilaginous wall, or just cartilage preservation because we cannot preserve, for example, the bones, or traditional rhinoplasty because in some cases we have to switch or to decide to perform traditional rhinoplasty. So the question we asked to ourselves was this one: what is the correspondence between the nasal profiles and the surgical procedures? Can we make a classification? And what are the results if we are performing, for example, a cartilage-only preservation in straight nose? What is happening if we are performing a full preservation in kyphotic noses? And this is the work we have done. And I'm very happy to share that with you. And so my analysis is this one. I check the radix, that is very thick bone, the keystone, that is overlap between nasal bones and septum, and the perlateral cartilages, so it is bony cartilaginous, and the supratip, that is strictly cartilaginous. And I will not talk about the tip today. So we have straight noses, tension noses, humpy dorsum, and difficult noses. So if I like the dorsum, this is a straight nose, straight sometimes. There is a small hump or a little bit convexity, it's a tension nose. You sometimes have a big bony convexity, it is kyphotic nose, and others are the other ones. And so we have seen that we have different types of preservation: full preservation, preservation plus resurfacing, or cartilage-only preservation, and traditional procedures. So, which are the main preservation procedure? I will just have this slide for that. You can keep that beside yourself. And so, from high strip, we have without dorsal disarticulation, Gola, Saban, Kovacevic. With dorsal cartilaginous disarticulation, partial lateral dorsal Ishida. With total disarticulation, I published already in 2012 this technique, and Ferreira published Speroof in 2016. While the technique coming from Cottle, without dorsal disarticulation, original Cottle, Spar from Davis, Finocchi and Tetris from Davis, but with total disarticulation was the first publication from Jorge Ishida before the end of the 20th century, and Jankowski more recently. So how to decide? So I did the comparison between my two studies, making at the end 672 consecutive primary rhinoplasty during this study. That were my personal cases. I can tell you that I did an objective study without any kind of kindness toward my technique. So in all the technique, I had at least 1 year follow-up. And I check my revisions. And look at that, it is interesting. My first paper, formal paper, I had only 3.50. I said, I'm a very strong surgeon. So my second study, I did during the second study, I found almost 10% revision. So something happened between the first and the second. And what happened is I commit the sin of pride. I said to myself, I'm very good. Now I can switch some steps. So I don't need to follow all the steps. I will just adapt the technique. And I was wrong because my revision rate jumped from 3.50 to almost 10%. And this is interesting because it's what I said. Even if you are an experienced surgeon, even if you are an expert in rhinoplasty, don't forget, follow the steps. It's critical in being safe. But not only the step, but also choosing the patient. This is interesting. Look at that. Dorsum shape. I had straight noses, tension noses, humpy, and challenging. How many straight noses out of 352? 129 straight noses. It means that 1/3 of my patients do not have any hump, no tension, nothing. They had high nose, but straight. And they wanted a nicer nose, but smaller. So in this case, it means that in straight noses, if you remove the dorsum, like in the classic techniques, you are removing a straight dorsum. Is it fair to the patient to remove a straight dorsum in these cases? I think no. But anyway, what I did in these straight noses, 88 cases, full preservation without any elevations of the soft tissues. In some cases, because of some angles and something, I decided to make rasping. To make resurfacing, and in some cases hybrid or even resection because the nose would be a little bit too big. Tension noses. Now let's see the second category. Tension noses. How many? A little bit, let's say 70 out of 350. It makes many patients. So almost. And what did I perform? Almost the same number of full preservation and preservation plus resurfacing. And we will see what happened with the results. So we can see about 45%. In humpy noses, I performed a little bit, let's say almost all the techniques. Full preservation, resurfacing, cartilage-only preservation or resection. And in challenging techniques, challenging patient, I decided in some cases to perform preservation plus resurfacing or hybrid. And interesting, we will see what happened in all these cases now. I would like to share with you. So in straight nose, can I go on, or do you want to?
Yes. Yeah, let's carry it. Finish this. It's good.
Okay, thank you. So straight nose, I told you 1/3 of my patients, straight dorsums. Full preservation in straight dorsum, 4% revision rate. You will say, okay, it looks a little bit too big, but because it's too much. Yes and no. Because remember, some patients that have not only straight but very big noses. I mean, sometimes I had to remove almost 2 centimeters height of these noses to make the nose smaller. So in this case, sometimes it is impossible to make this in one step. Anyway, so straight noses, full preservation, 3% revision. Tension noses, if I perform hump reshaping, preservation plus hump resurfacing, 1.40%. I say, okay, this is pretty good. Kyphotic noses, if I perform hybrid technique, I have also close to 2% revision. But what is interesting is this. If in these cases, tension nose, if I perform a full preservation, then my rate of revision is jumping from, let's say, 2% to 8%, 4 times. In kyphotic noses, humpy noses, if you prefer, if I perform a hybrid technique, then I have 2% revision. But if I perform just full preservation or hump reshaping, it jumps for 4 times at least. It means that it's not good. And in difficult noses, if I say, okay, I will perform a preservation technique in these cases, I have almost 25% revisions. What does it mean? It means that in difficult noses, don't try to perform any preservation, because we will make revision in 1 out of 4 patients. It's really too much.
And that's in somebody's hands who's been doing this for so many years. So that's not even in the beginner's hands.
Sure, this is in my hands. Probably in beginners it's worse. So, but when I listen of my friends say, okay, if I'm doing, for example, always hybrid technique. If I'm performing hybrid technique, I didn't do that in straight noses or tension noses. But if you are performing hybrid technique in all kind of noses, of course, okay, when it is a good indication, you will have good result. But if you are not doing that in good indication, you will have revisions, because you will be too aggressive for a nose that does not need to perform this technique. So just think about the benefit-risk ratio. This ratio is critical. Don't overperform a technique when it is not necessary. So I would like just to show again this. Straight nose, the best. So let's say that in conclusion. So in straight nose, en bloc, full dorsal preservation with no elevation of soft tissue is for sure the best technique. In tension nose, resurfacing is, in my hands, better. That can be, you can use whatever the instrument you like, rhinosculpture with piezo or a scalpel or whatever you like. And in kyphotic noses, the hybrid technique is for sure the best technique. And in the other noses, just go back to the other technique that give excellent techniques. But what I would like to go back to here, because many times I can read in the papers, okay, I have done 40 patients using this technique, let's say hand reshaping. Okay, you have done that, excellent. But if you're paid, and I have had 2 revisions, okay, good. It means that you have too many, it's too much. Because if you have 2 revisions out of 40 patients, it means that you are much more revision than if you had done the appropriate technique. So just remember that even if let's say you have done 10 patients, you have 1 revision, okay, you can say it's a very good technique. No, because what we want to get is not 1 out of 10, it's 1 out of 100. And then you will have more revisions if you are always performing the same technique. And the main message, take-home message of this table is that if you are always performing the same technique, the rate of revision will be bigger than if you are adapting the appropriate technique to the nose. So just make the selection. So you need to know at least a few techniques that will allow you to get the best results and the less rate of revisions. Now, if we look at how the septoplasty is can create some issues in the primary rhinoplasty procedure. As you know, we go always from the depth to surface, so we always start with the septoplasty. like the first step, and then we move to the rhinoplasty procedure. And then what we will perform on the rhinoplasty will depend on the septum stability. If the septum is very stable, or if you have no septoplasty, then of course you can perform exactly what I said before. But if you have performed the septoplasty and your septum is completely unstable, you will not cut, you will not make a high strip technique. Otherwise, you will have no more septum below your cartilaginous vault. And then you will be in trouble. So you have to perform all the Cottle technique, or you will have to perform a traditional technique. And moreover, if you have to perform a total septal reposition in very difficult septums, then you will have to, of course, to adapt the technique. So remember that the septum stability is an important criterion of evaluation of what we will do on the dorsum after the surgery. Look at this young lady. She's 15 years old, coming with her parents, saying that, her parents were worrying a lot because she didn't want to go out of the house since she is teenager. So the growth with the growth. She had a very nice nose when she was a child, and then with puberty she got this kind of nose. And the parents came to me saying, "Okay, doctor, can we do something without risking anything on our daughters?" I told them, "Okay, we can do a preservation." This was the simulation, because in preservation you do not make any damage to the growth of the septum, the growing area, and you are not making any issues with the nose. And anyway, even if we were doing something, if making the nose will stop the growth of the nose, it's good, because if the nose is going on growing, it's not nice. So anyway, in teenagers, 15 years old, this was a pre-op photo simulation, pre-op photo, post-op photo, pre-op profile, post-op profile. So the post-op is exactly what we plan to perform. This is not a simulation. This is not a tricky, I want a change result. This is the true result of this patient. I saw her, I will add this photo 4 years after now, and she has exactly the same nose, the same face, except that she's adult now and she has red hair and she changed her face. But anyway, in front view, what do we see? It is exactly the same young lady, but what changed is a little bit widening, flaring of the nostrils, because when you are deprojecting a little bit the tip, what is happening? The nostrils are flaring a little bit.
Ladies and gents, unfortunately, this is where the podcast is going to have to end. I really apologize about that. But we had a technical problem right at the end, and hence we've only been able to upload a certain part of it. So I really hope that you'll enjoy this, and come back again next week for some more exciting rhinoplasty podcast.